So I'd love to go ahead and we'll get started with the next part of our presentation. Right now. We use it when we're doing the question part. He's also a professor at UMass in medicine and microbiology, as well as molecular cell biology. That was one of my favorite classes when I was first on college. He's held multiple faculty positions at Universal Services University and the Health Sciences and University of California at San Diego. He got his education, his BA in medical degree at the University of Virginia in Charlottesville. He did his internship and residency at the Naval Regional Medical Center in San Diego, California, and then his fellowship in infectious disease at the National Naval Medical Center in Bethesda, Maryland. It's been our great pleasure at the Virginia Department of Health to also have Dr. Oldfield on our AIDS Drug Resistance Program Advisory Council, which is a critical program for people who need HIV medication. And it's my great pleasure and honor to introduce you to Dr. Edward Oldfield. Thank you.
Can you hear me in the back? It's okay? Great. Okay. So we're going to talk about the clinical presentation, diagnosis, and treatment of monkeypox. So classically, what we saw was fever, headache, muscle aches, and exhaustion after an incubation of about 7 to 14 days. Classically, within 1 to 3 days after the onset of the fever, so it was important, classically, you got the fever first, and then you got the rash, beginning on the face, then spreading to other parts of the body, the hands and the feet. And usually the lesions were all of the same stage. They were all pustules, or they're all macules, but they're all the same stage. But in the recent outbreak, it's changed quite a bit. And so what we're seeing now, so in the recent outbreak, though, the lesions, in many cases, they start in the genital region, the penis, the mouth, or anal region, and then they spread to the extremities. The first lesions have been noted to appear wherever the virus is inoculated, and it may precede the fever. Patients remain infectious, and this is very important until the scabs fall off and the skin underneath heals. And I'll show you some slides about how long that can take, a month. Patients may remain infectious, as we said, until scabs have fallen off. And usually they're going to be sick for at least 2 weeks, often 4 weeks. So this is not something that you want. This is an interesting study, and it just gives you an idea of how they present. 78% had anogenital lesions, 25% presented with proctitis. In mid-January, we had an HIV patient admitted to Norfolk General with proctitis and disseminated skin lesions. He had a viral load of 550,000 and a CD4 count of 250, and he had dropped out of our clinic for a year before he was admitted with monkeypox. 8% phenylketonuria, 43% though, they present with oral and perioral lesions, 10% with tonsillitis, and this is mainly from oral receptive sex. So it depends on how you get it, is going to be your presentation. 1 to 2 lesions only, and about 12%, 3 to 20, and 80%. Our patient probably had 6 lesions total. Localized lymphadenopathy, though, is very common, 85%, and often painful. So this is the way it progresses. You can see, I think it's easier to see on the Caucasian lower, starts with a flat macule, then it progresses to a papule, it fasciculates, then you get a classic pustule. There's usually a surrounding erythema, and they're quite painful. Then the pustule is going to rupture, you get a scab over it, eventually the scab falls off, and then the skin underneath heals. So on panel A, you can see here, lesion here, and then inside on the rectal mucosa, you can see here, though, you can see multiple lesions here in the rectal mucosa. These are very painful, and you can get coalescing necrotic lesions that take up significant part of the panel. These are extremely painful. Pain is usually one of your major clinical considerations in taking care of these patients. And then the perirectal lesions here, and you can see classic lesion here, and then this patient's got multiple lesions. In the perioral lesions, you can see around the mouth, tip of the nose, in the corner of the mouth. And again, you can get these coalescing, rather necrotic lesions on the tongue. And then the whole tonsillar bed now is a confluent necrotic lesion taking up the whole tonsillar bed. So, and just these are very painful. Perirectal lesions. And again, you can see they're pustular. They've got a little kind of indent, umbilication on the top of it. And then penile lesion here. Now this is just give you an idea of how long these can last. This is on the cheek up here, day 11, PCR positive. Day 21, he's still got a scab lesion here, which I think, even though it's PCR negative, I would consider still infectious. This is on the forehead here at day 11. This is 3 weeks later. He's still got an open ulcer on his forehead. And then this is the penile lesion. We're now day 28, and we have this big open sore on the penis. So these people can be infectious for a month. Also, we've seen some abnormal, different maculopapular morbilliform rashes, almost look like a drug rash. And these are two patients with monkeypox who presented with a morbilliform rash, more like a drug rash as opposed to your classic pustular lesions. I can tell you the patient that we saw at Norfolk General, I was not involved in the care. Had one of my partners from ID consulted dermatologist. It was a broad differential. He also had syphilis. He had classic pustular lesions with surrounding erythema, painful, looked just like disseminated gonorrhea. So there was a broad differential. They did get a monkeypox test. I can just tell you, we'll go into diagnosis. The test came back on the day of discharge. And this is a patient that should have been treated. Proctitis, viral load 550,000, CD4 count 250. And he never got care. He did do well. He's asymptomatic now, but it's a difficult diagnosis, not like disease you might think. So in the immunosuppressed or compromised, CDC's consulted for those with severe monkeypox. Most had HIV and a CD4 count under 250 or 200. They can have coalescing necrotic skin lesions. Some of them require extensive debridement, even to the point of amputation. Severe necrotizing lymphadenopathy. You can get urethral bowel strictures and scar formation, urethritis, penile necrosis. You can, if you have ocular involvement, you can get corneal ulcerations. Severe disease, again, they can become confluent, necrotic. The lymphadenopathy can actually become obstructive in the airways if they have pneumonia. You can get multi-organ involvement, encephalitis, myocarditis, ocular lesions, scarring lesions and strictures, and pharynx, vagina, anorectal strictures. And then a number has died from bacterial superinfections of these large skin infections and severe sepsis. So maybe if we could show these slides to some of our patients, maybe they would say, I want to be in the front of the line for that vaccine. So then the other side of the coin is there's actually asymptomatic monkeypox. So they took 200 patients appearing in an STD clinic, and they did PCR for monkeypox. And actually 6.5% of them were PCR positive. They then tracked down those 13 people, and they were all asymptomatic. They continued to follow them, and 2 of the 11 did develop symptoms later, but about 5% can be completely asymptomatic with monkeypox. So that's the other side of the coin, and obviously it would still be infectious. So monkeypox and HIV, overall, about 40% of all the patients are going to be HIV positive. Fortunately, 96% of them were on antiretroviral therapy in the United States, and 95% had an undetectable viral load. And so those people are going to do quite well. And in fact, when you look at them, their HIV status did not impact the incubation time, the clinical features, lesion number, or the time to crusting. So if you have a well-controlled HIV patient, they're going to do just about as well as somebody that's HIV negative. So in general, well-controlled HIV is not an indication for treatment with tecovirimat, but should be considered definitely for anybody with a CD4 count under 200, persistent viremia if they're not controlled, or a recent AIDS diagnosis. So monkeypox and HIV. So this was a study of over 300 monkeypox cases. 91% were people living with HIV. The median CD4 count was 211. Of course, you have AIDS if you're under 200. So these people were, on average, pretty advanced. But half of them did have an undetectable viral load. And if you look at those with a CD4 count under 100 and compare them to over 300, they had more necrotizing skin lesions, more lung disease, and more deaths. 25% of them died versus 0 if the CD4 count was over 300. Mortality, 27% if you get monkeypox and have a CD4 count under 100. About 4% mortality between 100 and 200. So all of your deaths and severe outcomes are going to be CD4 under 200. Nobody died with a CD4 count over 200. Other interesting thing is a quarter, you imagine you've got somebody who's out of control, like our patient, has been in care, you want to restart. Well, actually, a quarter of them had IRIS, or inflammatory reconstitution syndrome, where their recovering CD4s all went to the lesions, and the lesions flared, and they had a relapse of disease. So you have to be aware of IRIS when you start these people back on antiretroviral therapy. So as far as deaths are concerned, about 1.3 per 1,000 cases in the US, 38 total deaths. 95% of them were men who have sex with men, 87% African American. Median interval from onset to death's long time, over 2 months. These people just get progressively worse. 94% who died had AIDS. All had a CD4 count less than 100, and 96% were under 50 on their CD4 count. Important thing that the 27 who had data on their therapy, 25 received tecovirimat, which is usually very effective. And 60% actually had treatment start within 3 days of presentation. So they actually had early tecovirimat. 18 of 24 had vaccinia immunoglobulin. Some had cidofovir and some had brimcidofovir. Very importantly, almost 3/4 of these people who died had had at least a single dose of Jynneos. And why is that? You can't respond to a vaccine if your CD4 count's under 50. And so that's the problem. Even these people that have had the vaccine, if they have a low CD4 count, they're still at super high risk of bad disease. So just a little brief aside for monkeypox and healthcare workers. They had 300 Colorado healthcare providers exposed to patients with monkeypox. Almost a quarter wore all of the recommended PPE. But interestingly, where you're going to see them in the primary care setting, you may not even figure out it's monkeypox. You may do the whole visit, and then you say, oh, now I see you were complaining of X, Y, and Z. So only 4% had full PPE in primary and urgent care settings. And I think that's very understandable. 50% with high-risk exposure and 40% with intermediates, they receive Jynneos. Remember how effective Jynneos is after exposure? So if you're a healthcare worker, you get in a situation where you get a significant exposure, I would get in line for Jynneos and do it as soon as possible. None of these healthcare workers became infected. Overall, there have been about 250 cases in healthcare workers globally. Only 3, though, were felt to be occupationally acquired. It's just like with HIV. Lots of healthcare workers have gotten HIV, but very rarely was it actually exposure during work. It was non-occupational exposure. So, and we'll just go back to this for smallpox, post-exposure prophylaxis, even within 2 to 3 days gives you essentially 100% protection. So within 4 days, you get that vaccine, you're not going to get disease. Within 7 days, it still provides 90% protection. And actually, you can consider it even up to 2 weeks after exposure, because it may alter the clinical course. And actually, the way smallpox was eradicated from the world was ring vaccination. You'd have a case and you'd vaccinate all of the contacts, and that's how smallpox was eradicated from the world. Jynneos likely to provide similar protection for Mpox for healthcare workers and also household non-sexual contacts. On average, between 2 and 8% of household contacts will develop smallpox from non-sexual exposure. So you may want to consider offering Jynneos to all of the people in the household. So this is a little bit disturbing to me. Testing of 60 hospital services in four respiratory isolation rooms that had housed monkeypox cases. 93% of all of the surface samples they tested were positive for monkeypox by PCR. So you go in a room with a person with monkeypox where they've been there, or a house, you're going to collect samples or whatever, or do contact tracing, just presume all the surfaces are positive. PPE was positive in 1/3 of all the samples, including on visors and gloves. 25% of air samples were positive, 3 or 4 before or during bedding change. This is really dangerous in the hospital. I would not want to go into a hospital room just after they've done a bedding change. In fact, one of the healthcare workers that was infected with monkeypox got it right after a bedding change. 2 of 4 samples with viral cultures were positive, including an air sample positive by culture and an anteroom floor swab. So just be aware that there's going to be significant contamination of the environment where a monkeypox case was. So monkeypox diagnosis. So laboratory testing includes a non-variola orthopox virus. That includes the vaccinia, cowpox, monkeypox, and then an orthopox virus test, which also includes variola. If chickenpox is in your differential, which is really the main differential, that's a herpes virus, totally different. You need to send a completely different sample with a different request. So DCLS is a laboratory response network, advanced laboratory enrichment. They're going to test using a real-time PCR. It requires prior approval from VDH. So you're going to contact your local health department and contact the epidemiologist, present the case that you think needs testing. They'll give the approval. Okay, and so you can't just send a sample over to the health department. What they want is 2 to 4 dry swabs of lesions from different parts of the body, and then you're going to place it in separate dry, sterile tubes. They do not want viral transport media. They do not want universal transport media. So that's the way you would do it in your clinic. So you can find out who your local epidemiologist is just by going to the VDH website, and they are all listed. For Norfolk, it's Michelle Burnett. I called Michelle, not on her cell phone, on a regular phone, and I left a message, and she had called me back within 5 minutes, and we discussed the case, and she approved it. So that's what you want to do. If you want testing and you're in your private practice or whatever, call the local health department epidemiologist. They'll do the approval, and then you can send it. So this is another issue for in your clinic. You got to refrigerate the sample within 1 hour of collection, and then you've got to ship it refrigerated on ice packs. You want to package specimens with both a primary and a secondary container. And then you've got to complete the DCLS test request form. And then it's got to go by the routine DCLS courier. Turnaround time, once they set up the PCR at DCLS is 5 to 6 hours. I called DCLS, and she said, the director of the lab said they would set up Monday through Friday, anytime they got the sample. And she said, in fact, if it was an emergency, she would call the people in on the weekend to do the test. So it's not like the courier is going to take it to Richmond and it's going to wait till, oh, we only do it Mondays and Wednesdays. They're going to do it when they get the test, which is, I think, really important. So the positive test at DCLS we're considered presumptive now. If they say positive, it's a positive, and then they're going to send it to CDC for clade testing. If you only send them one sample, then they may get back to you and say, you got to go get a second sample so we can have something to send to CDC. So always send at least 2 samples. So this is, I talked to Latoya Griffin-Thomas, and she's the director at DCLS of the section that does the testing, and she told me they'll do it as soon as they get it. And I called her, talked to her. She answered the phone immediately, was very, very helpful. Now, this is one thing you don't want to do. This emergency department nurse took a needle to unroof the pustule so that she could get to the base of it to get a nice sample, probably a better sample for sure. She stuck herself in the needle. She got her first gyneos 15 hours after the needle stick. And she did, in fact, develop monkeypox, but only a single lesion right where she had the needle stick. And probably it was such a big inoculum that even the vaccine couldn't control the whole thing. But at least she only had 1 lesion. So don't unroof lesions. So this is 2 healthcare nurses developed monkeypox 5 days after collecting samples from a patient. They wore PPE except for gloves during the interview, okay, because they're just doing the interview. They've got all PPE on, but they're not getting ready to take the sample yet. So then they hand sanitize their hands. They put on their latex gloves. Prior to sample collection, there was never any skin-to-skin contact. And so most likely it occurred from contaminated fomites in the patient's home when they're there without their gloves. And so go back to that 93% of all surface samples are positive. You're going to go in to get a sample from somebody, have your gloves on from the get-go. Okay, now, frankly, if I'm in my practice, I'm seeing patients every 15 to 20 minutes. I've got 12 patients in a half day, and now I've got a suspected monkeypox. And this is frankly what EVMS has been doing from our infectious disease clinic since 2022, is we've referred them to Norfolk Health Department. Norfolk Health Department has an STD clinic that is Monday through Friday, 8:30 to 3. They know what they're doing. They've got the samples. They don't have to, the local epidemiologist can give the approval. The courier is right there. It's just a lot easier. Now, if we were seeing 50 cases a day in Norfolk, I think we could overwhelm the health department. Well, with us seeing once every 2 months, I think they can handle 1 case better than I can do it in the middle of my clinic. So testing is available from multiple private laboratories. Centera uses Quest. So our sample on the case we had in mid-January was sent to Quest. 5 days later, on the day the patient was discharged, the monkeypox test came back positive. Well, Tecovirimat, it's too late. He was fortunately getting better, but the commercial testing is going to take a while. It's going to go to Quest. And then I don't know if, if I was in a clinic and I sent my sample for monkeypox to the lab at Norfolk General, and I said, please send this to the health department so the courier can take it to DCLS. What would they do? They'd probably send it to Quest, right? So again, I think that the most efficient way to do it right now is to refer your patient to the STD clinic at your local health department. I would give them a heads up telephone call also, what was going on. Well, excuse me, and the other thing is they want the sample differently. They want this in viral transport media or universal transport media. They don't want it in a dry tube. So you have to send your sample differently depending where it's going. Okay, so this is interesting. The target for the PCR is the tumor necrosis factor receptor. And 3 cases reported from California had deletions in the target, and so they had false negative PCRs. But PCR based on the non-variola orthopox, which is what they do at DCLS, that's going to pick those up. So you have to remember that these people are sexually active, and just because it's monkeypox, you need to do tests for everything, especially with so much syphilis out there. 40% of monkeypox have had another STD in the last year. 10% have had 3. Our patient had syphilis on presentation plus monkeypox. So it's very, very confusing. So all should be screened for other STDs, a urine nucleic acid amplification test for GC and chlamydia. It's very important. If you only screen the urine, you're going to miss 70% of all GC and chlamydia in these patients. You also need to do a rectal NAT for GC and chlamydia. And for pharyngeal, you're only going to do the NAT for GC. And most oropharyngeal GC is asymptomatic. So you have to test all 3 sources. You want a syphilis serology and the HIV test. If it's positive, you want a CD4 count and a viral load. So STD testing should be done at least annually. But the other question is, shouldn't we be doing 3 to 6 months, really, certainly for HIV positive, for anyone taking PrEP, and for people with multiple sex partners? And I think that's definitely true. I don't think we test enough. A model from Australia demonstrated that increasing syphilis screening frequency from 2 times a year to 4 results in a relative decrease of 84% from their peak prevalence. Quarterly syphilis testing averted more than twice the number of syphilis cases compared with semi-annual, and as we mentioned earlier, where syphilis is skyrocketing, in particular congenital, and that means that pregnant women are not getting tested. Quarterly chlamydia and gonorrhea screening was associated with an 83% reduction in incidence. So certainly my PrEP patients, I get them back quarterly, although what I've seen is you get them quarterly for a while and then they don't come back for 6 months, and they don't come back for a year, and then they drop out of PrEP. So it's even these people are hard to get hold of. So as far as treatment, this is a wonderful reference. If you want one detailed reference to guide you on, it's Segrist in clinical infectious disease. Also a good reference by Rao and MMWR. So very important, there are no FDA-approved treatments for monkeypox. They're FDA-approved for smallpox. So what we're doing is using drugs approved for smallpox to treat monkeypox. So there's tecovirimat, brincidofovir, and vaccine immunoglobulin, and they're available from the Strategic National Stockpile. The only thing you can get by prescription is Vistide or cidofovir, and this is approved only for CMV retinitis. It's quite toxic. I would not recommend starting out with Vistide, but it is potential. They have shown efficacy against multiple animal pox viruses, so that's where the information comes from and why we're using them. They're available as expanded access investigational new drug protocol for tecovirimat, vaccine immunoglobulin, and then a single patient emergency use IND for brincidofovir. So for tecovirimat, this is the preferred first treatment for monkeypox. It inhibits the activity of the protein VP37, which prevents creation of virions that can be released from an infected host cell. So it prevents replication and dissemination of virus. Studies of monkeypox infections in primates and in rabbit pox model found markedly higher survival rates in treated animals. So I think this is going to be a very effective treatment. So this was actually a study of tecovirimat in people with HIV who had monkeypox, and they compared those treated within the first 7 days versus those treated after 7 days or never treated. And as I'll say in the next slide, the people treated early actually had much more severe HIV infection, and still, even knowing that, only 5% had disease progression with tecovirimat within 7 days versus 27% in those who either didn't receive it or received it late. And you can see here the mean CD4 count in the early group was 314 versus 433. Undetectable viral load in only 16% of the early versus 25%. Interestingly, if you look at them, those that were never treated or treated after 7 days, 61% met the criteria for treatment, but were not treated. 36% in the late or no treatment group eventually did receive tecovirimat on an average of about 10 days after symptom onset, which is not the optimal time to be treating somebody. And so their conclusion was our findings support starting tecovirimat in all people with HIV as soon as monkeypox diagnosis is suspected, not diagnosed, but suspected. The patient we had at Norfolk General who clearly needed treatment never got treatment. So who can you treat? The problem is you can only treat those criteria that are in the EAIND. And that is not anybody with HIV. Okay? That's people with severe illness requiring hospitalization, ocular, oral, or genital involvement, immunocompromised with HIV, CD4 count under 200, children less than 8 years old, in particular less than 1. In Africa, most of the patients that die of monkeypox are under 1 year old. Pregnant, breastfeeding, and of course, atopic dermatitis, eczema, psoriasis, and other skin diseases where they can disseminate in the skin lesions. In general, well-controlled HIV is not considered an indication to treat, but of course, CD4 less than 200, uncontrolled viremia, age within the last 6 months, or any of the above with HIV. So the dose, it's a 200 milligram capsule twice a day for 14 days. There is an IV formulation for someone who's got severe oral pain and can't take the pills. It does have cyclodextrin, so you have to be careful with a creatinine clearance less than 30. Has to be taken with a high-fat meal, and I'm talking 45 grams of fat or more, and it doubles the absorption if you take with a high-fat meal instead of. Now, it's available under an EAIND, and I've done many of these during the 45 years I've done infectious disease, and they were always a hassle. You know, if I had to do an EAIND, I was saying, my God, that's my day is gone. And for the next, and in particular, it was the Institutional Review Board, which was usually EVMS, the medical school. They wanted the consent form. They wanted to alter the consent form, on and on and on. Well, that's not true for this one. I'll go to that next. But what is recommended is that you enroll the patient in STOMP. And this is an NIAID-funded clinical trial led by the AIDS Clinical Trial Group, so all of their centers around the country. And it's randomized placebo-controlled arm, and there's also an open label arm. And patients can enroll for, and this is very important, suspected or confirmed. You do not have to wait for a positive test. Now, I called the STOMP Center. VCU was enrolling, they have stopped. They're talking about starting again, but there is no STOMP Center in the state of Virginia. So what they're going to do is refer you to a center outside Virginia, and you can do it remotely, but you're still going to have to get the testing yourself. And then they will take through all the forms, give them the tecovirimat, et cetera. But I said, well, I've got a patient in a hospital and he can't call you. I want to enroll. And said, no, this is for patient enrollment. So they want the patient to enroll. And I kept asking her, well, I'm the physician and I want to keep control of the treatment and be with the patient. So no, this is for patients only. So I was not very excited about STOMP. I would just prefer to do it myself. For the EAIND, for suspected or documented, go to you can just Google VDH monkeypox, go to for healthcare providers on the vertical left-hand column, treatment guidance, scroll down to TPOXX ordering. There's a registry and you can do it for providers or facilities. So your clinic can do it, the hospital can do it, and you can pre-position, and they will ship you tecovirimat for when you need it. And there'll be a box that says, are you an ID physician? You click yes, and then you can register yourself to get it, and they can ship it either to the patient or to you. And then took me 10 minutes. I did it just to practice. It took literally 10 minutes. So when I got to the IRB, it's pre-populated. You're using the CDC IRB, their addresses, telephone, everything is in there. Oh my goodness, I've died and gone to heaven. I was done with the EIND in like literally 10 minutes. Okay, so as we said, it can ship it to the patient, the provider, the facility, from VDH Central Pharmacy, and they will ship same day if they get the request before 3 o'clock in the afternoon with overnight shipping. And Alexis Page was very, very helpful to me. She agreed to let me put her cell phone number in there. And so if you have any issues filling out the EIND, just you can call her and she will help you navigate through, because she's going to want to make the final decision at VDH and handle the shipping. So she was absolutely wonderful. So the only thing you have to fill out after the EIND is you have to do the patient consent. Once you've done that, you don't have to do the patient intake form immediately. You can start tecovirimat before you do the intake. The form 1572, there's a clinical outcome form, and of course, a serious adverse event. And then there are other optional things you can do. But basically, you can get the tecovirimat pretty quickly to treat a patient. Be aware that it has a very low barrier for a viral resistance. A single amino acid change in the VP37 protein can lead to high-level resistance. End meeting. Is that done?
You're good.
Okay, so a greater than tenfold increase in the effective concentration that inhibits 50% of virus. They have tested over 5,000 samples at CDC, and resistance has been only 0.5%. So right now, we're not really worried about tecovirimat resistance. Unlike, very few drug interactions with tecovirimat. So that's really one nice thing, as opposed to Paxlovid, which has hundreds of drug interactions. This has almost none. The one issue you're going to get is it does interfere with rilpivirine. So if you have somebody on Cabenuva, you're going to have to add a 25 milligram rilpivirine to their Cabenuva for the duration of the tecovirimat and for 2 weeks after. Problem is that oral rilpivirine is only available from the company because it's not available by prescription. It's only part of the oral lead-in if you're going to do Cabenuva. So it may be a hassle getting it because so what the recommendation is, if you can't get the oral rilpivirine, then take them back to their old regimen before they're on Cabenuva. If you have the rilpivirine and then you have to go for 2 weeks, and you would not start Cabenuva, and anybody that's on tecovirimat, you're going to have to wait till 2 weeks after the tecovirimat, then you could start Cabenuva. Okay, so that's the only drug interaction I'm aware of that's of any significance. So additional measures, if you have somebody who progresses while they're on tecovirimat, or they have initial improvement and then they get worse, if you have concern for tecovirimat resistance, or they're allergic or they can't receive tecovirimat, then you may need to go to additional measures. There is a clinical consultation team that's available both by email and after hours at CDC, which is what I would recommend. Brimcidofovir, this is a prodrug of Vistide, and it selectively inhibits Mpox virus DNA polymerase. You can add it to tecovirimat. There actually is one animal study that shows they're synergistic. So you might do that if you have progression on tecovirimat. Has mainly GI toxicity, some neutropenia. You can't administer with protease inhibitors. It's much less toxic than cidofovir or Vistide, which had very serious renal toxicity. And of course, you couldn't use it with Vistide because it's a prodrug of Vistide. So this requires an emergency IND. So you can do online. I have not tried to do this, but there's a telephone number also that can give you assistance, and they have an emergency coordinator if you need brimcidofovir. I said cidofovir or Vistide, we used it a lot with CMV retinitis and got significant renal toxicity. It's a prodrug and it has to get into the cell and then be phosphorylated. But once it's phosphorylated, it lasts for 2 weeks. So it takes a long time to get started. Once it's gone, you only need to dose it once a week or every 2 weeks. So it's incorporated into growing DNA strands, slowing synthesis, it inhibits DNA polymerase. Usually we would give it with probenecid and a 1 liter normal saline, but I think I would go with brincidofovir rather than Vistide. I was thinking about, well, you could give 1 dose of Vistide and you'd have the person treated for a week, but I'd rather use tecaviramab. Vaccinia immune globulin, basically this provides passive immunity. And what they've done is they've collected pooled human plasma from people who are immunized with smallpox vaccine and with high titers. And so you're basically, where you'd want to give this is somebody who you were concerned could not get a robust antibody response. Somebody with very advanced HIV, somebody severely immunocompromised, a transplant patient. And it's basically 6,000, 9,000 units per kilogram as a single dose IV. And again, you have to do the EAIND for them. Ocular monkeypox, trifluorogene viroptic, a thymidine analog, interferes with DNA synthesis. So you'd want to use these eye drops if you have somebody with ocular infection. Okay, certainly, unless you've seen a lot of monkeypox cases, I think certainly if things weren't going just right, I'd be on the telephone to the CDC to get input from them. I've been doing this long enough to have put pride behind me. So I'll just end with the beginning. And really the beginning is about preventive measures, right? Because if we do preventive measures, we never have to get to the diagnosis and the treatment. So first, personal measures. Take a temporary break. I had one patient, I asked him, how many different partners do you have in a year? He said, well, at least 300. And I said, well, how can you possibly be doing this over 300? He said, easy. And he takes out his cell phone and it says, 27-year-old male, 300 feet away. It's that easy. And people do have a lot of partners. So take a break. That increase your exposure until you're 2 weeks after your second dose of vaccine. And this will greatly reduce your risk. Limit your number of sex partners to reduce your likelihood of exposure, and avoid spaces like back rooms, saunas, sex clubs, private and public sex parties, where you're going to have intimate, often anonymous sexual contact with multiple partners. So make a habit of exchanging contact information with any new partner to allow for sexual health follow-up if needed. I don't think that happens often enough. Talk with your partner about any monkeypox symptoms and be aware of any new or unexplained rash or lesion on either of your bodies. Condoms may protect from exposure to monkeypox, but you're going to have skin lesions in lots of different places. So it's really going to be probably minimal protection. Gloves might also reduce the possibility of exposure, but they have to cover all the exposed skin and be removed very carefully because they're going to be contaminated afterwards. So you could contaminate yourself as you take the gloves. Don't touch another person's rash or scabs. Don't share eating utensils, cups, clothing, bedding, towels, personal grooming devices. They're all going to be contaminated. Wash your hands soap and water. Use an alcohol-based hand sanitizer after contact with infected people. Wear a mask in situations where you may have lengthy or close face-to-face contact with people who may be infected. Remember, we did have those aerosol samples that were positive, although I won't think of this as transmitted that way. It happened. So this is actually a survey, and it showed that actually about half had reduced their number of sex partners, 50% reduced one-time sexual exposures, 50% reduced sex with partners met on dating apps or at sex avenues. So there was, in fact, a significant change in behavior. Men with more than one sex partner in the preceding 3 weeks had 500% higher risk of being infected with monkeypox. One-time sex accounted for about half of all monkeypox cases, and decreasing your one-time partnerships by 40% decrease your risk of monkeypox by about 25%. So changing behavior is important in addition to the vaccine. And then we want to, if we have monkeypox, protect others. So if you and your partner has recently had monkeypox symptoms, have a new or unexplained rash anywhere in your body, don't have sex, see a healthcare provider. If you don't have a healthcare provider or insurance, go to your local health department. You can get free treatment for your STDs. Be aware that in some cases, symptoms could be mild, and some people may not even know that they have monkeypox. Best way to protect yourself and others, avoid sex of any kind, kissing or touching each other's bodies while you're sick, especially avoid touching any rash. Don't share towels, fetish gear, sex toys, toothbrushes, and abstinence during active infection and for up to 8 weeks after recovery is the UK recommendation, and certainly that's what I would recommend. We saw how long those lesions persisted, so they're going to be out of commission for a while. And so just in summary, for diagnosis, testing is by a VDH DCLS, approval from your local health epidemiologist, or you can send it to a commercial lab. Centera is going to use Quest, or refer the patient directly to the local health department for testing. Treatment is very important. It's for suspected or confirmed. That case we had at Norfolk General, the team waited until they got the test back. They should have just gone ahead on day one, but that's the retrospective scope. Certainly immunocompromised, especially HIV with CD4 count under 200, or those that have uncontrolled viremia. Refer to the TPOXX trial, but when I called, it was for patients only. It wasn't for providers. Or complete the EAIND, and you can get it shipped to you or to the patient. And then, of course, prevention. We want to vaccinate or have behavior changes. As we saw on the slide, you want both behavior change and vaccination. And with that, I will end.